Welcome to the Deep Dive. This is where we take your sources, could be lecture notes, articles, whatever you send us, and we really dig in to pull out the key insights you need. Fast.
Yeah, think of it as us sorting through the pile with you, figuring out what's crucial, what connects, what you really need to know.
And today, wow, we have a stack that's right in the wheelhouse for nursing students. We're hitting those big respiratory concepts: gas exchange, oxygenation, perfusion, all stuff that's, fundamental for your coursework and definitely for the NCLEX.
Absolutely. And let's be honest, respiratory can feel dense. There's a lot going on, physiology, different diseases.
It really can.
So our mission today is to try and make it clearer, connect those dots for you, make it stick.
Exactly. So let's jump in. We'll start with some core respiratory diseases from the lecture info you sent and kind of build out from there.
Sounds good. Okay, first up is asthma. Your notes define it as a disease with reversible airflow obstruction.
Okay, reversible. That word jumps out immediately. That's the big difference compared to, say, COPD, right?
That's the key distinction, absolutely. And what's behind that obstruction? Well, it's basically chronic inflammation. This inflammation makes the airways hyperresponsive. They kind of overreact triggers.
Twitchy airways.
Pretty much, yeah. Leads to bronchospasm, the muscles tightening up. Plus, the inflammation itself, involves mediators like histamine, causing more blood flow, fluid leak, extra mucus, all narrowing the airway.
Which gives you those symptoms we all recognize. The wheezing, feeling breathless, that chest tightness, the cough.
Exactly. And an interesting point, during an attack, it's often harder to get air out because of the narrowing. So air gets trapped, and the little air sacs, the alveoli, hyperinflate.
Makes sense. What kind of things trigger these attacks?
Oh, it's a long list. Allergens are big ones, pollen, dust mites, environmental stuff like cold air, pollution. Exercise can do it, stress, infections, even acid reflux, GERD.
Right, and the typical symptoms. You mentioned cough, wheezing.
Yeah, cough. The wheeze often starts on expiration when breathing out shortness of breath. But also, look for chest tightness, maybe a fast heart rate. The patient might seem anxious, even find it hard to talk in full sentences during a bad attack.
And they often happen more at night or early morning.
That's classic, yeah.
Your materials mention something important too, airway remodeling. What's that about?
That's a really critical point. If the inflammation isn't controlled over the long term, it can actually cause structural changes in the airway walls, scarring, thickening, and those changes aren't reversible.
Wow. So letting it go untreated doesn't just mean symptoms, it means potential permanent damage down the line.
Yeah.
Really highlights why control meds are so important.
Exactly. Now, for diagnosis, the gold standard, especially for kids over 5, is spirometry.
Okay.
You're looking at lung function, specifically how much air can be forcefully exhaled. In asthma, that FEV1-FVC ratio is reduced, showing obstruction.
And for tracking things at home?
The peak flow meter is the tool. Measures the fastest speed you can blow air out. Your notes use that traffic light system.
Green, yellow, red.
Yep. Green, 80-100% of personal best, you're doing well. Yellow, 60-80% means caution, might need to step up treatment. Red, under 60%, that's a danger zone. Need that rescue inhaler, probably need to seek help.
Got it. What about blood gases, ABGs, during an attack?
Okay, so you'd expect low oxygen, hypoxemia. Initially, because they're breathing fast, trying to compensate, they might blow off too much CO2, leading to hypocapnia and respiratory alkalosis.
But there's a catch, right?
There is, and this is a huge NCLEX point. If you see the PaCO2 start to rise during an asthma attack, that's a really bad sign.
Why is that?
It means the patient is tiring out. They can't keep up that rapid breathing anymore. They're starting to retain CO2. It signals impending respiratory failure. Big red flag.
Definitely something to watch for. And management.
It's about control and rescue. First line for long-term control are inhaled corticosteroids, ICS. They tackle that underlying inflammation.
Okay.
For quick relief of symptoms, you use short-acting beta agonists, SABAs like albuterol. They relax the airway muscles quickly.
Rescue inhalers.
Exactly. And sometimes long-acting beta agonists, LABs, are added with an ICS for better long-term control, but never used alone for asthma.
And a practical tip from the notes: rinsing the mouth after using an ICS inhaler.
Yes. Crucial nursing point. Helps prevent oral thrush, a common side effect.
Good tip. Okay, let's shift now. The other big obstructive disease, COPD. Chronic obstructive pulmonary disease.
Right. And the key difference here, unlike asthma, is that COPD involves airflow obstruction that's progressive and not fully reversible.
Got it. Progressive and not fully reversible.
It's usually a combination of two conditions, chronic bronchitis and emphysema. Most patients have features of both.
And the main cause.
Overwhelmingly, it's cigarette smoking, like 80–90% of cases. Repeated irritation leads to chronic inflammation.
Similar to asthma in that way.
Well, yes, inflammation is key, but the results are different. In COPD, it leads to thickening and scarring in the airways, narrowing, and importantly, loss of the lungs' natural elastic recoil. The springiness is gone.
Which leads...
That loss of recoil means air gets trapped during exhalation. The lungs stay overinflated hyperinflation, which causes that characteristic barrel chest shape you often see.
Okay.
And this whole process just speeds up the normal lung function decline that comes with age. Plus, it puts a strain on the right side of the heart.
Leading to potential complications.
Yeah, like pulmonary hypertension, high blood pressure in the lung arteries, and eventually cor pulmonale, which is right-sided heart failure caused by the lung disease itself.
Okay, let's quickly touch on those two components, chronic bronchitis first.
So the classic definition is a productive cough bringing up sputum for at least 3 months a year for 2 years running. You get increased mucus production, thickening of the bronchial walls, a narrower lumen, and the little cilia that clear mucus don't work as well.
Makes sense they'd be prone to infections then.
Very much so. The notes mentioned the blue bloater description, sometimes associated with dominant bronchitis, often overweight, can be cyanotic, bluish tinge, lots of cough and sputum, maybe edema, finger clubbing.
And emphysema?
Emphysema is more about destruction of the actual air sacs, the alveoli. The walls break down, you lose elastic tissue.
So less surface area for gas exchange.
Exactly. Impairs oxygen getting in hypoxemia and CO2 getting out hypercapnia, leading to respiratory acidosis, especially later on. You also lose capillaries in those damaged areas.
And the description sometimes used here is pink puffer.
Right. Often thinner, might have less cough or sputum compared to bronchitis, but they use pursed lip breathing, have that barrel chest, and you can really see them using their accessory muscles just to breathe.
But the main symptoms overall for COPD are?
Chronic cough, sputum production, and the big one is progressive dyspnea, shortness of breath that just gradually gets worse over time, eventually even at rest.
Smoking is the main risk factor, but what else?
Secondhand smoke, definitely. Certain occupational exposures to dusts or chemicals. And there's a genetic factor, too, alpha-1 antitrypsin deficiency. That can cause COPD in younger people who've never smoked.
Diagnosis, similar to asthma, spirometry.
Yep. Spirometry confirms it, shows that persistent airflow limitation, that reduced FEV1-FVC ratio. It's also used to stage severity and track progression.
Management goals.
Mainly reducing symptoms and reducing risk, especially exacerbations. And your sources really hammer this home. Smoking cessation is the single most effective thing someone can do. Cost-effective, too.
Now, oxygen therapy and COPD. This seems like a really critical area, especially for exams.
Absolutely vital to understand this. The goal is usually to keep PaO2 at least 60 or SaO2 at least 90%. But, and this is the crucial but,
Go on.
in some patients with chronic severe COPD, they've become accustomed to having high CO2 levels. Their bodies have adapted. So their main stimulus to breathe isn't high CO2 anymore. It's actually low oxygen, the hypoxic drive.
Okay, so you've given too much oxygen.
You can potentially knock out that hypoxic drive. They might breathe less, retain even more CO2, and that can lead to serious problems, even respiratory arrest.
Wow, so the nursing implication is huge. Use oxygen cautiously.
Use low-flow oxygen, typically starting at 1 to 2 liters per minute via nasal cannula for these specific patients. And you have to monitor them incredibly closely. Respiratory rate, oxygen saturation, level of consciousness, and checking ABGs is often necessary to make sure you're helping oxygenation without dangerously increasing CO2.
Got it. Low flow, close monitoring for those chronic CO2 retainers. What about meds?
Bronchodilators are the cornerstone for symptom management. They help open the airways. But unlike in asthma, where ICS are first line for inflammation, in COPD, bronchodilators are key for symptoms, though they don't really slow the disease decline itself.
Okay.
Corticosteroids, usually oral or IV, are mainly used for acute exacerbations, flare-ups, and vaccinations, pneumococcal and annual flu shots are super important to prevent infections.
Pulmonary rehab comes up too.
Yes, highly beneficial. Exercise training, education, support improves exercise tolerance, quality of life, and can reduce hospital stays.
And airway clearance techniques.
Important for those with sputum. Things like controlled coughing or huff coughing, chest physiotherapy, CPT, postural drainage, and breathing retraining.
Like pursed lip breathing. How does that help?
Pursed lip breathing is great for COPD. Breathing out slowly against pursed lips creates a little back pressure in the airways. This helps keep the smaller airways from collapsing early during exhalation, allowing more trapped air to get out, reducing that hyperinflation feeling.
Makes sense. Okay, next disease in the materials, cystic fibrosis, CF.
Right. This one's different. It's genetic. The most common fatal autosomal recessive disease in Caucasians need to inherit a defective gene from both parents.
And the core problem.
It's a faulty protein called CFTR. This protein normally helps move chloride ions across cell membranes. When it doesn't work right,
Things get thick and sticky.
exactly, you get abnormally thick, viscous secretions in multiple organ systems, lungs, pancreas, intestines, reproductive tract, and also increased salt in sweat.
Which leads to the diagnostic test.
The sweat chloride test, yes, it's definitive. Levels of 60 middle EQL or higher on 2 separate occasions confirm CF because that faulty CFTR can't reabsorb chloride properly in the sweat ducts.
And in the lungs, those thick secretions cause huge problems.
Massive problems. Mucus plugging blocks airways, leading to chronic inflammation, chronic infection, and eventually bronchiectasis, permanent damage, and widening of the airways.
A specific bacteria concern.
Pseudomonas aeruginosa is a big one. Colonization with Pseudomonas is linked to faster lung function decline. Very hard to eradicate once established.
And outside the lungs, the pancreas.
Major impact. The thick secretions block pancreatic ducts, preventing digestive enzymes from reaching the intestine. This is pancreatic insufficiency.
So they need enzyme supplements.
Yes, with every meal and snack, lifelong. Otherwise, they can't digest fats and proteins properly, leading to malnutrition, steatorrhea, fatty stools. They also need extra fat-soluble vitamins A, D, E, and K.
Other issues.
GI problems, CF-related diabetes can develop, and infertility is common, especially in males.
Management sounds incredibly complex.
It is multi-pronged. Controlling infections with cycles of antibiotics, often inhaled or IV. Aggressive airway clearance is vital CPT, vests, nebulized meds like Dornius alpha, which thins mucus, and hypertonic saline, which draws water into airways. Plus, huge focus on nutrition, high calorie, high protein, those enzymes and vitamins. And now, there are CFTR modulator drugs that target the underlying protein defect for specific mutations, which is a major advance.
Okay, shifting to pediatrics now. RSV, respiratory syncytial virus.
Very common, highly contagious virus. It's the main cause of bronchiolitis inflammation of the small airways. The bronchioles primarily in infants and young children, especially under 2. Also affects immunocompromised adults.
And it causes obstruction.
Yeah, inflammation and lots of thick mucus block those tiny airways.
Who's most at risk?
Premature infants, kids with underlying chronic lung or heart conditions, those not breastfed, exposure to secondhand smoke, kids in daycare or crowded settings.
Symptoms to watch for?
Starts often like a cold or runny nose, maybe fever, cough, poor feeding, but it can progress. Look for signs of increased work of breathing, air hunger, retractions, skin pulling in around ribs or neck, crackles or wheezes on auscultation, maybe cyanosis. A very rapid respiratory rate over 70 is concerning. Decreased breath sounds can mean severe obstruction, apneic episodes, restlessness, or the opposite, listlessness.
And your notes highlighted some key signs needing urgent help.
Yes, nasal flaring, that rapid breathing, tachypnea, and listlessness or lethargy. Those are signs the baby is in significant distress and needs immediate medical evaluation, likely EMS call.
Is there prevention?
For high-risk infants, yes. A medication called palivizumab, it's a monoclonal antibody given monthly during RSV season.
Nursing care focuses on
Supportive care mainly. Isolation, first contact, and droplet precautions, it spreads easily. Keep them hydrated and nourished. Often small, frequent feeds work best because feeding takes effort. Elevate the head of the bed. And constant, close monitoring for those worsening signs. Oxygen if needed.
Okay. Also in the pediatric section, SID, sudden infant death syndrome.
Such a tragic topic. Defined as the sudden, unexplained death of an infant younger than 1 year, even after a full investigation.
Peak age.
Usually between 2 or 4 months, with most cases about 80%, happening by 6 months.
And the risk factors really center on
The sleep environment. This is where nursing education is absolutely critical. Unsafe sleep practices are major risk factors.
like
Things like placing the baby to sleep on their stomach or side, using soft bedding like pillows, thick blankets, quilts, bumper pads in the crib, sleeping on a soft surface like a couch or adult bed, co-sleeping, sharing a bed with the infant, having stuffed animals or loose blankets in the sleep area.
So the prevention message is clear.
Crystal clear. Safe sleep saves lives. The ABCs. Alone, on their back, in a crib, or bassinet or pack and play. Firm, flat mattress, only a fitted sheet, nothing else in the crib. Every single sleep time.
That back to sleep message is paramount.
Absolutely. Also important to mention risks like maternal smoking during pregnancy or substance use, secondhand smoke exposure after birth, and prematurity. And of course, providing sensitive, non-judgmental emotional support for families who have experienced such a devastating loss is a vital nursing role.
Okay, let's move to some direct airway management techniques covered. Tract care and endotracheal intubation.
Right, both about maintaining a patent airway. An ET tube, endotracheal tube, goes through the mouth or nose into the trachea, usually for mechanical ventilation. Tips should be about 2 centimeters above the carina where the trachea splits.
And a tracheostomy.
That's a surgical opening, a stoma directly into the trachea in the neck where a tract tube is inserted. Can be temporary or permanent. Tract tubes, and sometimes ET tubes, have cuffs, little balloons that inflate to seal the airway, which is necessary for positive pressure ventilation. Some tract tubes are fenestrated, meaning they have holes, which might allow the patient to speak if the cuff is down and the upper airway is clear.
Nursing care for these patients must be intense.
It really is. Constant monitoring is key. Preventing complications like dislodgement, obstruction, infection, maintaining airway patency often requires suctioning.
And the notes stress sterile suctioning.
Absolutely crucial. The airway is a direct route for infection. Sterile technique is non-negotiable for tracheal suctioning. Meticulous oral care is also vital to prevent ventilator-associated pneumonia. And don't forget the patient's experience dealing with anxiety, communication challenges since they often can't speak. Huge psychosocial needs.
Good point. Lastly, basic chest tube management.
Okay, chest tubes are drains. Used to remove air, fluid, or blood from the pleural space, the space between the lung and the chest wall, to allow a collapsed lung to re-expand. Think pneumothorax or hemothorax.
Key principle for the drainage system.
Always keep the collection system below the level of the patient's chest. Gravity's your friend here, prevents backflow into the pleural space.
Nursing assessment involves
Checking the drainage amount, color, consistency, and assessing the system itself, particularly the water seal chamber, if it's a water seal system. Air leaks. Continuous bubbling in the water seal chamber usually means there's an air leak somewhere, could be at the insertion site, a loose connection, or rarely from the lung itself.
It's normal then.
Intermittent bubbling that corresponds with the patient's breathing, especially exhalation or coughing, is often normal, especially if treating a pneumothorax. Also, you should see titling the water level in the water seal chamber rising and falling slightly with breathing. That indicates the system is patent and reflecting pleural pressure changes. If titling stops, the lung might be re-expanded or the tube could be kinked or blocked.
Okay, and securing everything.
Vital. Tape connections securely. Maintain an occlusive dressing over the insertion site. And bedside readiness is critical.
What should be at the bedside?
Emergency equipment. 2 padded hemostats or clamps for potentially clamping the tube briefly if the system breaks. Sterile water in case the tube disconnects from the system. And petroleum gauze or an occlusive dressing in case the tube accidentally comes out.
Right, so if the tube does accidentally come out.
Immediately cover the site with a sterile occlusive dressing, taped on 3 sides usually, to prevent air from sucking into the chest cavity, and notify the provider immediately.
And if the tubing disconnects from the drainage unit.
Don't clamp the tube generally. Instead, immediately place the end of the chest tube into a bottle of sterile water or saline about an inch or 2 deep. This creates an emergency water seal, preventing air entry while you quickly get a new drainage system set up.
Excellent safety points. Okay, we've covered a lot of ground on specific conditions and interventions. Now let's try to connect some dots using insights from your other sources, the slides, the textbook bits focusing on assessment, oxygenation perfusion links, key meds, and pulling it all together for practice and the NCLEX.
Right, making those connections is key. So, thinking about assessment again. Beyond just listening for breath sounds, your sources highlight specific adventitious sounds. We mentioned wheezes for narrowed airways, crackles for fluid or airways popping open.
Raunchy, too.
Yeah, raunchy often sound like snoring, suggests secretions in larger airways, and might clear up a bit with coughing. But one sound that's an emergency is stridor.
High-pitched on inspiration.
Exactly. Usually heard best over the neck. It indicates upper airway obstruction could be swelling, a foreign body, requires immediate action.
The textbook also mentioned feeling for tactile fremitus.
Yeah, those vibrations when someone speaks. Increased fremitus suggests consolidation, like in pneumonia where sound travels better through solidish tissue. Decreased fremitus happens with things like emphysema where there's more air trapping or pleural effusion.
And percussion tapping on the chest.
Gives clues too. Normal lung is resonant. Dullness suggests fluid or solid tissue underneath. Hyperresonance might indicate a pneumothorax or severe emphysema. Voice sounds changing also indicate density changes. Now let's explicitly link this to oxygenation and perfusion. Your sources state it clearly. The respiratory system needs the cardiovascular system for perfusion for blood flow.
Can't have gas exchange without blood flow.
Precisely. Gas exchange happens where the alveoli meet the capillaries. Oxygen diffuses in, CO2 diffuses out. But that only works if blood is actually flowing through those capillaries. You need both ventilation, air, and perfusion, blood.
Which brings us to VQ mismatch. V for ventilation, Q for perfusion.
Right. A mismatch means ventilation and perfusion aren't balanced in certain lung areas. You could have a low VQ or shunt blood flows past alveoli that aren't getting enough air, like with mucus plugging or atelectasis. The blood doesn't get oxygenated properly.
Or the opposite.
Or a high VQ, dead space alveoli are getting air, but there's no blood flow going past them, like with a pulmonary embolism blocking an artery. Air is ventilated, but no gas exchange occurs.
And either type of mismatch leads to
Hypoxia. Low oxygen in the blood. It's a core problem in so many respiratory diseases. Asthma attacks, COPD, CF, and pneumonia, PE. Understanding VQ mismatch helps explain why patients become hypoxic.
And we shouldn't forget the heart's role in the delivery of that oxygen, right, from the perfusion material.
Absolutely. Cardiac output, how much blood the heart pumps per minute, is crucial. Even if the lungs load oxygen onto the hemoglobin perfectly, if the heart isn't pumping effectively, low cardiac output, the tissues won't get enough oxygenated blood delivered. It's all connected.
Okay, let's bring in some pharmacology connections from the slides. ACE inhibitors, they're Ipril drugs.
Yeah, common blood pressure meds. Noted side effect. That nagging, dry, non-productive cough. Your assessment info even listed it as something to consider when figuring out why someone has a cough.
Beta blockers, the ol drugs.
These block beta receptors.
Yeah.
Beta-1 receptors are mainly in the heart. Blocking them slows heart rate, lowers BP. Beta-2 receptors are mainly in the lungs. Stimulating them causes bronchodilation.
So blocking beta-2
can cause bronchoconstriction, which is why non-selective beta blockers, the ones that block both beta-1 and beta-2, have to be used very cautiously, if at all, in patients with asthma or COPD. They could potentially trigger or worsen bronchospasm. Huge safety point.
Definitely. Diuretics were mentioned too, like furosemide.
Often used for fluid overload, which can happen with cor pulmonale and COPD, or general heart failure, which often coexists. Key nursing monitoring, blood pressure, urine output, and electrolytes, especially potassium and sodium levels, which can drop.
And anticoagulants, heparin and warfarin.
Relevant because patients with chronic lung disease are often less mobile, increasing clot risks like DVT or PE. Need to know the monitoring tests. PTT or APTT for heparin, PTINR for warfarin. And the #1 nursing responsibility is monitoring for any signs of bleeding.
Okay, pulling this all together now for practice, for exams, it seems like recognizing those key assessment findings is step 1. Stridor is an emergency. Rising PaCO2 in asthma is an emergency. Specific lung sounds point towards specific problems.
Exactly. And knowing the why behind interventions is crucial. Why teach pursed lip breathing? Why is sterile suctioning so important? Why time CPT before meals? Why monitor oxygen so carefully in some COPD patients? Why emphasize safe sleep? It's connecting the pathophysiology to the action.
And anticipating complications. Knowing what status asthmaticus looks like, or a COPD exacerbation, or signs of a pneumothorax after chest tube insertion. And knowing those immediate first actions.
Like the occlusive dressing for tube removal or the sterile water for disconnection. Those aren't just test answers, they're critical interventions.
So we've really walked through core diseases, connected them back to oxygenation, perfusion, assessment, key meds.
Hopefully providing a framework, not just isolated facts. It's about building that clinical reasoning, seeing the cues, understanding the physiology, and knowing what to do.
And really hammering home that these systems, respiratory, cardiovascular, are deeply intertwined. You can't really understand one without considering the other.
Absolutely. Holistic care depends on seeing those connections.
Okay, to wrap up, let's leave you with a thought to chew on. We talked about how quickly respiratory status can change, especially in someone with chronic lung disease who suddenly gets worse.
Yeah, they can go from stable to respiratory distress pretty fast sometimes.
So in that moment, when your patient suddenly becomes acutely breathless, what single assessment finding or what single immediate nursing action do you think is the absolute top priority? Something to consider.
Keep digging, keep making these connections in your studies and clinicals.
Thanks so much for joining us for this deep dive.